So I repeat, in this lecture, we will talk about drugs for mood disorders. So particularly, ang mood disorder nga ato ang i-tackle is depression. So ang drugs nga ga-involve in the management of mood disorder, in the management of depression is the drugs antidepressants. Now, sa ato ang existence, no, as human beings, we all naturally experience mood changes. Natural na siya sa ato, di ba? Mag-change atong mood. Pwedeng in a span of week or in a day. In a day, pwede mag-change atong mood. That is normal. For instance, di ba, sometimes we feel happy, we feel energetic, we feel optimistic. Then, the other times, we feel sad. Opposite naman, we feel sad, we feel irritable, or kanang mga negative. Okay? But for us, mga normal persons, there are not naatay mga mood changes. Okay? What I mean is, sa ato a normal person, kana nga mood changes, dili gid siya mag-last long. Diba? Dili gid for a month, kuan gid ta, sad na lang gid ta. Okay, so normally na lang gid tay mood changes, pero dili mag long yahang period bitaw of mood changes. So again, I repeat, sometimes we feel kung taas, okay? We feel, let's say, happy. Okay? Then there are times nga we feel sad. Okay? So that is normal. So despite that mood changes in a day or in a week, okay, we still tend to manage, no? Ma-manage gyapon nato siya, ma-neutralize gyapon na siya, no? As a normal person, we can still manage that in our normal nga daily routine. However, for some people, no, there are certain nga mga life experiences nga not always simple para sa ilaha. Okay? There are cases nga ang person might experience, let's say, very long periods of sadness, okay, or guilt, okay, or very long decreased ang iyahang interest in activity. So naiingana sa some other people. Okay, depende na siya sa mga factors, sa life experiences nga iyahang ma-encounter. Okay, now this condition, kana ganing long periods na of sadness, long periods of decreased interest sa mga normal activities, this is what we call depression condition already. Okay, depression. Now, when we talk about depression, sometimes, okay, this occurs alone. Okay, sometimes for a person, depression ra gyud ang iyahang na feel. Okay, wala tong hyperactive, itong opposite sa depression. Okay, so I repeat, when we talk about depression, this may occur alone, but there are times nga parte ito ng much more complex or larger disorders. Okay, so say for example, familiar mo sa bipolar disorder. So from depression, okay, yung depression niya, okay, pwede mo shift, okay, into manic disorder or mania. Okay, again, ang persons with bipolar, no, disorder, ga-experience siya og periods of depression, long periods of depression, then alternating with periods of mania, okay, or manic disorder. Pag mo tag manic disorder, mania, dili ni siya maniac ha, kanang kalye nga term, mania, it has something to do with moods nato. Okay, it is when a person abnormally becomes optimistic, pero abnormal. Okay, nga stage nga optimistic, abnormal nga stage nga euphoric, okay? Abnormal nga stage nga energetic, na sobraan bitaw. That is manic or mania. Okay? However, the alternating moods of a person having bipolar disorder do not just happen in a day. Okay? Hindi po ibig sabihin na may bipolar agad yung tao kapag in just a day lang may mood changes siya. Okay, for instance, sa morning, very energetic siya, very happy siya. Then biglang irritable pagka later afternoon ang tao. That is not bipolar disorder. Okay? Ang bipolar disorder, it is when yung periods of depression, okay, alternating to periods of mania, okay, it happens for a span of months. Okay, let's say for the first 4 or let's say 4 to 6 months. Okay, for the first 4 to 6 months, depression occurs, and then the following months, okay, onwards, the following months, that person shifts to having manic disorder. Okay. So, again, dili ta makaingon, dili gyud siya joke nga moingon ka sa tao nga ni bipolar man kaday. Okay? Bipolar lagi na siya, dili na siya joke nga term ha. Kamo as medical student, paramedical student, you have to be responsible in using the terms, no, sa medical mga medical terms. Okay, dili niyo siya gamiton sa pang joke-joke, delikado yun siya nga sakit. Okay, so later sa latter part sa ato ang discussion, we will discuss mood stabilizing agent, particularly for bipolar disorder. Okay, but for the main focus of our lecture, ang main focus sa atong lecture is more on the pharmacology of antidepressants. Okay? Pero since naatay mga drugs that are also important, no, mga drugs nga mood stabilizers pa, very important po sila in your part as pharmacist, no, para kabalo mo sa MOA ng mood stabilizers, how do they work, no, para ma-manage ang bipolar disorder. Okay? So again, mag-una ta sa antidepressants. Okay? So kung yung antidepressants, ito yung group of agents na very useful in the management of depression. Okay? Sige. Now, first and foremost, before ta understand, okay, or i-discuss ang MOA ng mga antidepressants, it is very important for you to understand first the underlying problem that causes depression. Ngano di ay, no, ga experience og depression ang usa ka tao. Okay, so based on monoamine hypothesis, okay, based on a theory, okay, termed as monoamine hypothesis, it has stated that ang depression daw is most likely resulted from deficiency, okay, deficiency of serotonin and norepinephrine in the brain. So mo na siya ang pinaka-underlying problem. Okay? Mo siya ang key factor, key problem bakit may depression. It has something to do with the neurotransmitters. Okay? Na ay changes sa activity ng neurotransmitter, particularly ang involved na neurotransmitter are serotonin and norepinephrine. These are monoamines, diba? Monoamine neurotransmitter. Mababa yung level during depression. Now, with this idea, this theory therefore explains the principal nga action ng mga antidepressants, diba? Given this idea nga During depression, monoamine neurotransmitter like serotonin and norepinephrine are in low levels in the brain, then ang inyo ding idea, kung mayroon tag antidepressants, ilang typical nga goal, okay, ilang typical nga goal, let's say, na ay antidepressants, their typical goal is to increase the serotonin and norepinephrine. Diba? Mo gina ang typical goal sa antidepressants. They are made available to increase the monoaminergic activity, okay, via increasing serotonin and norepinephrine particularly. Okay. Now, based on the specific mechanism of actions ng antidepressants, okay, for the purpose of enhancing the serotonin and norepinephrine levels, there are different classes of antidepressants. Okay, different classes of antidepressants. Particularly, we have selective serotonin reuptake inhibitors. Okay. Yes, Miss Abigail, you have question?
Ma'am, I accidentally pressed that.
It's okay. So again, example of this class of antidepressants, we have selective serotonin reuptake inhibitors, or this is abbreviated as SSRIs. Dili kayo usually ginagamit gamit ni siya kaning longest niya nga term katurang abbreviated. So kung yun kag SSRI, so alam niyo na, selective serotonin reuptake inhibitors. Another is serotonin norepinephrine reuptake inhibitors, abbreviated as SNRIs. Tricyclic antidepressant, shortened as TCAs, monoamine oxidase inhibitors, MAOIs, okay, MAOIs or MAOIs, depende sa inyo. Then we have the atypical antidepressants. Okay, by the way, kaning first, okay, the first four, particularly first four antidepressants, they are generally termed as typical. Okay, they are what we call the typical antidepressants. Okay, they are termed as typical antidepressants. Now, when we say typical antidepressants, this group of agents, meaning to say, they produces the typical nga MOA, okay, that is expected of an antidepressant. Unsa di ay ang dapat expected nato nga MOA ng antidepressant, 'di ba? Yung ultimate effect dapat is focused on increasing serotonin and increasing norepinephrine levels. Yan yung typical nga goal gyud ng antidepressant based on the underlying problem sa depression. Mababa man ang serotonin or epinephrine, dapat typically kung mag-produce ka, mag-synthesize kag antidepressant, then it must have that activity. No other additional or miscellaneous activities. Now, those are typical antidepressants. Okay, then when we say atypical antidepressants naman, so it produces this time additional or miscellaneous action aside from enhancing serotonin, enhancing norepinephrine, monoaminergic nga neurotransmission. Okay? Now, before we discuss each of the MOAs ng 5 classes, okay, kani siya, before nato siya i-discuss, let's have a quick review first on this part. Okay? Ayan. So, review sa serotonergic neurotransmission and the noradrenergic neurotransmitter. Not neurotransmitter, neurotransmission. Okay? This is very important for you to easily understand later on how antidepressants work. Okay? So, for instance, we have on the left side, kaning nasa left side nato is, diba, serotonergic neurotransmission. Then on the right side, noradrenergic. Yung noradrenergic, ito yung norepinephrine. Di ba? Norepinephrine, that is the principal neurotransmitter sa adrenergic system. Okay? So, noradrenergic. Now, itong nasa taas na mga neurons, okay? Itong mga nasa taas nga neuron, say tawag ani, di ba? These are the pre-synapse. Okay? And then this space, in between, ito yung cleft, synaptic cleft. Then itong nasa baba, ito naman yung post-synapse. Okay, so review ra ni siya ha. Now, sa post-synapse, so obviously, diri mag-interact, no, diri mag-bind ang neurotransmitters. Okay, producing response. So, kailangan yun mag-bind. Kailangan na ay mo bind sa receptor para na ay response, na ay action, na ay activity. Okay, so again, just to reinforce your knowledge, your prior knowledge on this part, serotonergic, noradrenergic neurotransmitter, ato i-review. Okay, let's start with presynapses. Recall, under synapses, SSR, mahitabo is storage, synthesis, storage, and release of neurotransmitter. That's what happens here in presynapse. Again, storage, synthesis, release. Okay. Now, in the presynaptic serotonergic neuron, okay, particularly, ang mahitabo diri is serotonin will be synthesized. Okay, so you have serotonin. It will be synthesized from what amino acid? It will be synthesized from amino acid tryptophan. Diba? Now, from this, from this serotonin, okay, nga na-synthesize, it will then be stored in the vesicles, diba? From this, ma-stored siya into the vesicles. So, kaning mga color blue, these are serotonin being stored in the vesicle via what transporter? Via VMAT. I-scan lang ninyo inyong notes ha, via VMAT. Now, from that, sa vesicles, of course, mag-wait siya nga ma-depolarize ang buong cell membrane ng presynapse para ma-release siya into the cleft. Now, let's have the other side. Okay? Presynapse ng noradrenergic neuron. Again, let's have here on the right side. Okay. Sa noradrenergic neuron naman, presynaptic noradrenergic neuron, we have norepinephrine. Okay, norepinephrine that is being synthesized, okay, being formed inside the vesicles. Naalala, yung norepinephrine, it is being synthesized. Di maklaro, no? Ana. It is being synthesized inside the vesicles. Okay? How? Scan nyo inyong notes ha. It is via the action of the beta hydroxylase, dopamine beta hydroxylase enzyme. Okay? Action ng dopamine beta hydroxylase enzyme towards dopamine. Okay? So, gikan na siya sa dopamine. Okay? So, again, na-form ang norepinephrine inside the vesicle via, di ba, converting dopamine into norepinephrine inside the vesicle. Okay? Now, initially, kaning dopamine, this is formed from an amino acid. And what is that amino acid? Di ba? The precursor is tyrosine. Okay. So, nahitabo from tyrosine, convert siya into dopamine. Dopamine has to be stored in the vesicles. Tama? To avoid premature metabolism in the presynapse. Now, inside these vesicle, yung dopamine will be converted into norepinephrine via the enzyme dopamine beta hydroxylase. You have your notes already for this. So, review lang niya siya. Okay? So, ma-stored siya, the same thing, via VMAT. Diba? Via VMAT. Same naman na sila. Okay? Monoamine. Okay? So again, as mentioned, norepinephrine is synthesized from dopamine inside the vesicle. Now, kapag na-depolarize, okay, na-depolarize yung presynaptic nga cell membrane, na-depolarize, okay, depolarize, excuse me, that will ultimately trigger the release of norepinephrine, diba? It will trigger the release of norepinephrine, okay, on this side. Then, on the other side, kapag na-depolarize naman yung serotonergic, presynaptic serotonergic cell membrane, then that will trigger the release of, ayan, serotonin. Okay, so these are serotonin. So they are now made available in the synaptic cleft. Okay, now what I wanted to emphasize here is the fate, no? Yung fate, yung destiny ng mga neurotransmitters in the cleft as sa padulong unsa ilang destiny. Okay, once ma-release na sila sa cleft. So number one, recall, obviously, available ng mga neurotransmitter in the cleft, they are destined to bind, no, sa postsynaptic receptor. So binding to postsynaptic receptors. Okay, so for noradrenergic neurotransmission, yung mga postsynaptic receptors, halimbawa, we have alpha 1, beta 1, diba? Dito, mas na ay affinity si norepinephrine. We're talking about norepinephrine here, ha? Kaya mo man ang involved sa depression. Okay? So, alpha 1, beta 1, iyahang affinity ng mga receptor. For serotonin, anong tawag in general sa mga receptors ng serotonin, di ba? Serotonin receptors. Okay? So again, number one fate is of course binding to postsynaptic receptors. And binding to this postsynaptic receptors, these are evidence already nga enhance, okay, ang neurotransmission. Okay? Ang pagpasa ba sa impulse, pagpasa sa balita from the presynapse going to the effector organ. So proof ito na naipasa yung impulse, no, towards the effector organ. So naa na dayoy ma-produce nga effect. Okay? Response. Number two, another fate is all about termination. Okay, termination of neurotransmitters, okay, in the cleft. So this is another fate, destiny ng mga neurotransmitter serotonin or epinephrine sa cleft. Pwede sila ma-terminate. Okay? Removal, no? Terminate, removal of this neurotransmitter in the cleft. So obviously, when you hear about this fate involving termination, what will happen to the transmission, okay, of impulses? Reduce, no, ang neurotransmission, reduce ang serotonergic neurotransmission, reduce ang noradrenergic neurotransmission with termination of neurotransmitter in the cleft. Di naman sila available to bind in the postsynaptic receptor. So opposite, decrease, reduce yung neurotransmission of the impulses. In particular, there are three mechanisms. There are three mechanisms, okay, of termination ng neurotransmitter in the cleft. Again, there are three mechanisms, okay, that causes termination of neurotransmitter of serotonin, of norepinephrine in the cleft. So una, this is not so significantly observed. We have diffusion. Okay, diffusion of neurotransmitter into the systemic circulation. So from here, from the cleft, mo diffuse siya into the systemic circulation. Okay, so that's one. Another mechanism of termination ng neurotransmitter is metabolism. Okay, mag-undergo sila og metabolism via MAO. Okay, via monoamine oxidase in particular. Okay. Obviously, inyong knowledge, kung maintag metabolism, we are degrading, no? I-inactivate nato ang neurotransmitter. I-inactivate nato sila, so reduce gyud ang level nila, leading to reduction of monoaminergic neurotransmission. And lastly, reuptake process. Diba? Reuptake process. This is another mechanism of termination ng neurotransmitter. What is your knowledge about reuptake process, diba? Based on your knowledge, when we talk about reuptake nga process, this is the most significant, most pronounced ba nga fate of neurotransmitter whenever it is available in the cleft. Tama? Once you'd mo release mo release ang mga neurotransmitter like norepinephrine, serotonin sa cleft, most of the number of those transmitter will be reuptaken back to the presynapse. Okay? They will be reuptaken back to the presynapse. Again, kung may yung tag-reuptake, ang serotonin, ang norepinephrine, they will re-enter. Okay? They will re-enter. Okay? Reabsorbed. Okay? Transported back to the presynapse. Okay? So, gikan sa cleft, mubalik sila sa presynapse. Okay? So, for serotonin, it is being reabsorbed via the transporter. Recall, the transporter is called SERT. Diba? Sa inyong notes. SERT, ang pangalan, serotonin transporter. Yan yung kailangan para ma-transport back, ma-re-enter back sa presynapse ang serotonin in the cleft. For norepinephrine naman, it is being transported via NET. Diba? Via norepinephrine transporter. Now, dapat inyong idea ha, basta reuptake process mo decrease ang level ng norepinephrine, serotonin sa cleft. Kung mo decrease silang availability diri sa cleft, wala gid kaayoy mo bind sa postsynaptic receptor, decrease ang iyang activity, decrease ang iyang response. Now, another thing is, once ang serotonin or norepinephrine will be get absorbed or reabsorbed back into the presynapse. Okay? Once mubalik sila sa presynapse, they are partially packaged into the vesicle. So balik sila partially. Ang partial part, sulod sa vesicle. However, partial also, yung partial number also ng mga reuptaken na neurotransmitter, norepinephrine, serotonin, they are broken down. They are being degraded. Okay? They are being degraded into their inactive metabolites. And that is via the action of the enzyme MAO. Okay? MAO. So, muna siya, dira, then musulod si MAO, monoamine oxidase. Okay? So again, partially, pag reuptake, partially, ma-re-enter siya sa vesicle. It will be transported into the vesicle, but partial part will be degraded, okay? Will be broken down via the enzyme monoamine oxidase. So ang purpose ni monoamine oxidase is metabolism, degradation, broken down ng norepinephrine and serotonin. Okay? So as observed, ang gi-highlight na ako, metabolism via MAO, reuptake process. These processes, okay, they eventually result to decrease levels of norepinephrine and serotonin in the cleft. Okay? Decrease level ng serotonin, norepinephrine in the cleft. Now, with low levels ng norepinephrine and serotonin sa cleft, lesser ang transmission ng impulses ana. Kay lesser man ang ni-bind sa post synaptic receptors. Lesser ang ni-bind, lesser ang action, lesser ang response, lesser ang monoaminergic response. So it is very important for you to understand this process in order for you to understand the mechanism of action ng antidepressants because it has something to do with this. Okay, say for example, okay, pag sinabing, kanisa, sabi dito, number 1 and 2, serotonin reuptake inhibitor. So obviously, sabutable raman no, yang gina-inhibit ang serotonin reuptake. Number 2, serotonin and norepinephrine reuptake inhibitor. Okay? So ang ilahang action, okay, is towards here, 'di ba? Ang reuptake with SNRI, ang reuptake ni norepinephrine, ang reuptake ni serotonin. Okay? Therefore, pag inhibition of reuptake process, what will happen? Does it lowers or enhances the level of serotonin or norepinephrine available for action kapag na-inhibit yung reuptake process? Lower or enhance action. Oh, very good.
Enhance.
Oh, very good. Enhance. Okay? So, as mentioned, unsa dapat ang goal ng mga antidepressant, typical goal ng mga antidepressant, it is to enhance serotonin and norepinephrine. Okay? So, dira ang importance, musulod ang importance ani nga process. Excuse me. Yeah, another example. Okay ni, para na mo'y idea diretso. Number 4, monoamine oxidase inhibitors, di ba? Yang gina-inhibit ang enzyme nga nga monoamine oxidase. Okay? Gina-inhibit niya ni pag sinabing MAO ay inhibitor, inhibited yung MAO. Okay? Now without MAO, obviously, this also enhances the levels of norepinephrine and serotonin kay pigil man ang metabolism ng norepinephrine and serotonin. So maka-enhance siya sa monoaminergic neurotransmitter. That is why MAOIs, monoamine oxidase inhibitors, they are also classified as antidepressants. Okay? So this time, let us proceed now to the drugs. Okay? Starting with SSRIs. Okay? So, kabalo naman sa term ha, selective serotonin reuptake inhibitor. So based sa term itself, as reflected sa term, obviously, it selectively inhibits, blocks serotonin reuptake. How? Unsa niya pag-block sa serotonin reuptake? Via blocking the transporter SERT. Okay? So kung balikon nato ni iyahang action, pag sinabing SSRI, iyahang gina-inhibit, gina-block ang transporter nga SERT. Okay? So kung walay transporter, dili gyud ma-reuptaken pabalik ng pre-synapse ang serotonin. That's why continuous ang iyahang availability diri sa cleft. Wala siya lain paingnan, mo bind gyud siya sa post-synapse, di ba? So enhance, maka-enhance siya sa level ng serotonin, okay? In the cleft available for action. So examples of SSRIs, fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, escitalopram. Okay? Now, for most of the patients, okay, with the usual nga signs, usual nga symptoms of depression, these SSRIs, okay, they are the common nga antidepressants that are being prescribed. Okay? Sila gina always basta na ay kana ma-diagnose psychiatric lugar diagnose ka, okay, you have depression. Ang hihatag yun sa imuha ang first line, maya siya ang term. First line gyud nga ginahatag nga agents, antidepressants are the SSRIs. Okay, first line. Okay? First line sila kasi they have lesser associated toxicities, lesser adverse effects. Kaya ga-focus ramang yun sila sa serotonin. Okay? And there are studies nga between norepinephrine and serotonin, ang pinaka-common yun nga underlying problem sa depression is sobrang baba ng serotonin. Kasi di ba serotonin is the happy pill? Okay, so sobrang baba ng serotonin. Okay? That's the time depression happens. Okay? So, kani siya nga drug, selective raman sila sa serotonin reuptake inhibition. Okay? So, lesser therefore ang ilahang adverse effect. Okay? Di man nila igon ang katong reuptake ng norepi, etc. Okay? Now, based on the MOA, mechanism of action, diba, selective serotonin reuptake inhibition, ang mga SSRIs, they are indicated sa mga patients with serotonin syndrome. Okay? Kanang mga pasyente nga naanay serotonin, kung may kag serotonin syndrome, sobrang excessive, okay, yung serotonergic effect nila. Okay? Grabe ang levels of serotonin nila. So, contraindicated yung mga SSRIs. Okay? Kapag mayroong serotonergic syndrome ang patient, nagkakaroon ng excessive serotonergic, okay, effects. Okay, so contraindicated kay ang mahitabo kung maghatag kag SSRI, di ba mo increase ang level ng serotonin. Nya na naman siya daay serotonin syndrome. Okay? So ang mahitabo, higher risk siya sa drug-to-drug interaction. Drug-to-drug interaction ni siya, no? Ma-augment, mo-enhance, mo-exaggerate ang serotonin's activity in the body. So bawal, contraindicated siya to patients with serotonin syndrome, ang mga SSRIs. Now, with regards to adverse effects, okay? With the adverse effects, side effects, excessive nga stimulation, again ha, basta kay adverse effects, kay kanang related rin siya sa action. Diba, ga-enhance siya og release ng serotonin. Now, kung excessive stimulation ng serotonin nga receptor sa brain, what will happen? That may lead to insomnia. That may lead to increased anxiety. That will lead to irritability. Kaya over naman kaayo na stimulate man kaayo. Okay? So, munang adverse effect. Kami itong na-toxic level na ng mismong drug. So, that's the time na ay adverse effect side effects. Whereas, kung excessive naman na stimulation ng serotonin in the spinal cord, that results to sexual dysfunction. Example, erectile dysfunction. Okay? Another thing, kapag naman na-enhance ang serotonin level sa let's say CNS, related, nausea and vomiting. Okay? Na-enhance ang serotonin level sa stomach, sa GIT, that will cause diarrhea. So these are adverse effects, no, related to SSRIs. Okay? Now, I wanted to emphasize, okay, this warning, okay, nga incorporated sa insert sa package ng fluoxetine. Okay, fluoxetine is marketed under the brand name Prozac. Okay, fluoxetine. Ayan. So with regards with fluoxetine, siya yung only FDA-approved drug for the treatment of depression among adolescents. Okay? Again, siya yung only FDA-approved na drug for the treatment of depression among adolescents. Okay? And tandaan, yung gamot na ito, Sa iyang inserts, di ba ang mga drug, naman yun na sila yung mga inserts, aware man mo anang mga inserts. Okay, sa inserts, always na nakabutang dito, sa inserts niya, kani nga black box nga warning. Di ba? Naka-box, color black. Mura na siya, black box, warning na siya. Kailangan yun ang basahon, no? In which yung warning lang, it tends to remind, no, the patient taking that drug, especially the guardian nga ga-help o monitor sa mismong patient, no, nga dapat i-monitor gyud ang pasyente taking Prozac. Okay? Kay nga naman, kung inyo ning basahon, there is higher risk of suicidal tendency with this drug. Okay? So, kailangan with proper monitoring. Nadira ang reason, you can just read this. Okay? Basahin nyo lang tandaan with fluoxetine, naano siya black box warning sa yung inserts because of its higher suicidal tendency. Okay? Now, in addition to treating depression, okay? In addition to treating this, in addition to treating depression, di ba, SSRI, very good sila in treating depression. Ang SSRIs, they may also be used in treating other psychiatric disorders. So, example, PTSD, di ba, sa kung hilig mo mga Grey's Anatomy or whatsoever nga mga medical related nga mga series, PTSD is post-traumatic stress disorder. Okay? Then generalized anxiety, OCD, familiar man mo ani, di ba? Yung obsessive compulsive disorder. Okay, so pwede din merong mga SSRI nga use in the management of other nga psychiatric disorders. Okay? Now, done with SSRIs. Okay? So, dali naman masabtan ang iyang MOA based on the term ng mismong class of drug, selective serotonin reuptake inhibitor. Now, let us proceed to SNRIs. Okay. SNRIs naman, or the serotonin, take note ha, serotonin, norepinephrine, reuptake inhibitor. So, kung ato ning balikon nga process, okay, kanya itong gamiton ba? Okay, serotonin reuptake inhibitor siya, so na siya ability. Wala, di man ma-colorize, sige. Na siya ability to inhibit serotonin transporter, okay, kay serotonin reuptake inhibitor man siya. So, yung target is katong transporter para dili mapigilan yung reuptake. Okay, para mapigilan yung reuptake process. Then, naapod siya ability, okay, to inhibit norepinephrine reuptake. So, via inhibiting the norepinephrine transporter. So, inhibited, continuous ang availability ng norepi, serotonin in the cleft. No choice, mo bind yun na sila sa, receptors. Okay, so yan yung, MOA ng SNRIs. Okay, so again, I repeat, SNRIs, they also work, okay, via inhibiting reuptake of serotonin. Then at the same time, napod sila ability to inhibit reuptake of norepinephrine transporter. Okay, so as a result, there would be increase both ng serotonin and norepinephrine levels sa cleft. Okay, then leading to enhanced monoaminergic neurotransmission. So what are examples of SNRIs? Examples, we have duloxetine, venlafaxine, desvenlafaxine, lemomil-nazepram. Now, if SSRIs, diba, SSRIs, sila yung first line, antidepressants. Okay, first on the choice. Okay? SNRIs naman, pag SNRIs, they are considered second. Okay? Second line. Okay? Antidepressants. Okay? Again, they're considered second line antidepressants. Now, for the clinical applications, the same with SSRIs. Okay? Ang SNRIs, they are also used, of course, for depression based on their MOA. Gina-enhance man nila ang norepi, gina-enhance ang serotonin. So, pwede gid siya for depression, antidepressant gid siya nga classification. And another thing, pwede din siya for anxiety, panic disorder. However, unlike SSRIs, ang mga SNRIs, they can be used to reduce neuropathic pain. Okay? That effect is actually related sa iyang action towards enhancing noradrenergic activity in the CNS. Wala namang activity, di ba, ang SSRI sa norepinephrine. Okay? Nga activity. Focus naman to siya sa serotonin. Okay? That is why meron siyang ability to reduce the neuropathic pain. Now, with regards to side effects, okay? Side effects based on its mechanism of action gihapon. Okay? They are associated with increased BP, increased heart rate. Asa man ni connected, okay, nga adverse effect. Aha nga MOA, recall, norepi, kung may tag norepi, nasiyay affinity, enhance ang level ng norepi. Nasiyay, kung available ang norepi, yung postsynaptic receptor ng norepinephrine are alpha-1, beta-1. Alpha-1, pag na-activate, vasoconstriction, tama? Vasoconstriction. That causes increased BP, hypertension. Tama? Beta-1 receptor, asa makita sa heart, positive chronotropy, positive dromotropy, okay, etc. That's why na ay increase heart rate, positive chronotropy. Okay, so related lang na siya sa iyahang MOA. Okay, now another adverse effect also specific sa duloxetine, kaning duloxetine. Take note, this is associated with hepatotoxic adverse effect. So, hepatotoxic siya nga drug. Okay? Nagkukos siya ng hepatotoxicity. Venlafaxine, ito naman cardiotoxic nga drug. Okay? Cardiotoxic nga drug. Okay? Sige. Let's proceed to, done with SNRIs. Okay? Let's proceed to TCAs, or the tricyclic antidepressants. Okay, TCAs, tricyclic antidepressant. Yung term na tricyclic, that is derived based on the core nga chemical structure of each compounds. Okay, ilang chemical structure, kung inyuhan ni siyang natakol sa medical organic chemistry, ang ilang mga structure ani amitriptyline, etc., naa sila'y 3 rings, 3 cyclic rings, no, connected together. That's why tricyclic, no, antidepressant. So based lang na siya sa iyang chemical structure. Talking about MOA, mechanism of action. Okay, they are found to have similar action with SNRIs. Similar lang. Ang say action ng SNRIs. Inhibit reuptake ng serotonin and norepi. Again ha, reuptake. Kung reuptake, ilang target is ang transporter. Si SERT o si NET. Okay? Ganon din yung activity ng TCAs. Okay? These agents also inhibits reuptake of both serotonin and norepinephrine. However, take note, these agents, kaning listed agents, they exhibit different levels of selectivity in inhibiting reuptake process. In particular, ang Pcas, they show greater activity towards inhibition of norepinephrine reuptake. Okay? Nagyapon sila ability to inhibit reuptake of serotonin, pero mas pronounced, mas significantly observed ang inhibition sa reuptake ng norepinephrine. So examples of TCAs, we have amitriptyline, amaxapine, clomipramine, doxepin, imipramine, kapoy yun kayo no, mag-pharma. Inyo yun memorize kung mag-board exam. Tanan yun drugs. Naiuban nga di makayag mnemonics, inyo yun siya memorize. Okay? Now, in addition to their blocking activity, diba, na sila blocking activity towards SERT, towards NET. Okay? Aside from that, okay, they are also thought to have additional anti-HAM. Naalala yung anti-HAM activity? Okay? Naa sila'y blocking effects towards histamine, alpha receptor, and muscarinic receptor. Okay? However, these blocking activity towards histamine, alpha, and muscarinic receptors, they are not related anymore to their antidepressant activity. Okay? Ang related lang silang antidepressant action is ito. Upon inhibition ng reuptake of serotonin, inhibition ng reuptake of norepinephrine, mura siyang related sa antidepressant. That's why nabilong sila as antidepressant drugs. Pero kanila nga effect, naa sila additional anti-HAM activity, ito ay related sa ilahang adverse effects. This explains much about their adverse effects. Okay? Now, with regards with the clinical applications, okay, or clinical uses ng TCAs, they are mainly used, okay, for depression. Okay? However, due to their broad ang ilahang mechanism of action, they may also be used in treating other nga mga problems, medical problems. Say, for example, si amitriptyline. It is very useful in prevention, in treating neuropathic pain. Si amitriptyline dire. Okay? Amitriptyline. Very useful din siya. So aside sa iyang action as antidepressant, naaman siya broad nga mechanism of action, pwede siya for the treatment of neuropathic pain, for migraine, okay, pwede din. On the other hand, yung doxepin, okay, yung doxepin naman, pwede naman siya, okay, in the management of insomnia. Kasi, meron siyang significant activity towards blockade of histamine 1 receptor. Blockade of histamine 1 receptor. Diba? Side effect, kapag na-block ang H1, mga H1 blockers, side effect, sedation. Okay? That's why pwede siya in the management of insomnia. Okay? Diba insomnia, maglisod og tulog ba? Okay? Now, let's have the adverse effects. Again, basta adverse effects, related lang na siya sa action. Okay? Mechanism of action ng class of drug. Now, blockade, okay, of alpha receptor, that leads to orthostatic hypotension. Okay? This is due to iyahang alpha receptor blockade activity. Ano na lang. Kaya na may minus. Kaniha basta na minus block. Okay, blockade. Okay. Whereas ang sedation, common side effect ni siya due to blockade of histamine receptor, particularly histamine 1 receptor. Okay? And finally, kapag blockade naman of muscarinic, okay, receptors, Then, ang pinaka-adverse effects related is the anticholinergic side effects. What are examples of anticholinergic adverse effects? Diba? Opposite ng dumbbells. Opposite ng dumbbells, we have dry mouth. Okay, what else? Blurred vision, katong cycloplegia. We also have constipation. No? What about sa urinary bladder? There is urinary retention. Okay, so these are common nga anticholinergic side effects in relation to its activity towards blockade of muscarinic receptor. Take note ha, kaning tulo, okay, this is because of their additional miscellaneous nga blocking activity. But again, this is not related to the antidepressant activity nila. Okay, this only explains the adverse effects, okay, ng mismong TCAs. Okay, now other adverse effects, okay, include QT prolongation. Okay, this is manifested by irregular rhythm ng heartbeats. Okay, so more siya arrhythmia-like nga symptoms. Then ang pinaka-most common, i-highlight ni ninyo, this is the most commonly observed, no, nga adverse effect among PCAs. Okay, tricyclic antidepressants. This is also because of the blockade, particularly sa histamine 1 receptor. Kung mag-search mo, histamine 1 receptor blockade, that causes increase of appetite. Kaya nagkakaroon ng weight gain. Okay? So, gamay na lang. Let's have the, ayan, MAO. Okay? So, monoamine oxidase inhibitors. Okay? MAO-Is, okay, inhibitors ng enzyme MAO. Okay, so i-recall sa nato unsa ang MAO. Monoamine, okay, oxidase, monoamine oxidase. Anara? Dili ni siya. Okay ha. Sayop ni siya. MAO. Sakto ni MOA na, MOA, sakto na. Okay, so dire na ako ibutang. Pag MAO, okay, monoamine oxidase nga enzyme. Katong enzyme sa enzyme. Okay? That enzyme degrades, no? It metabolizes, okay, monoamine nga neurotransmitter. Example, serotonin, norepinephrine. Okay. Now, when we talk about MAO enzyme, okay, na siya duha ka subtypes. Okay, it exists in two subtypes. We have MAO A and MAO B. Okay, MAO sub A, MAO sub B, and these are differently distributed, no, sa bodily tissues. Okay, na ay monoamine oxidase sa brain, na ay MAO sa stomach, na apoy sa liver. So, enhance ang ilang distribution sa body. Now, with regards to monoamine oxidase A, okay, tandaan, this type of enzyme, siya yung ga-metabolize sa serotonin and norepinephrine. Okay? Again, it is the one nga related sa atong topic nga antidepression. Okay? Antidepressant agents. Okay? Siya man ang ga-involve sa metabolism of serotonin and norepinephrine. Now, other monoamine containing substances like tyramine and histamine are also being metabolized by MAO A. Okay? Whereas ang MAO B, monoamine oxidase subtype B, it preferentially metabolizes naman only dopamine. So, tandaan ha, only dopamine, MAO B. Okay, ang iyang ginametabolize, dopamine lang. Now, because of the underlying problem I have mentioned about depression, di ba, it involves decrease in norepi, serotonin level kapag depression. Okay? Sa brain ni siya ha, sa brain, dili ni siya sa stomach or so whatsoever, sa brain ni siya nga mga neurotransmitter nga atong gipasabot kung depression na. Okay? Mababa yung level ng norepinephrine and serotonin sa brain. Having that idea, therefore, kung ingon ta og MAO inhibitors, okay? Ang inhibition towards MAO-A, okay? Ang responsible for its antidepressant effect. Okay? So kung hatagan ka og drug nga MAO-B inhibitor lang, it has nothing to do with your depression. Dili na niya kaya i-treat ang imuhang depression. Kaya look at the action ng MAO-B. Diba? Ang MAO-B, it only involves dopamine. Dopamine has nothing to do with your condition, depression. So meaning to say, kung maingon ditag monoamine oxidase inhibitors, ang gahatag yun o responsibility nga na ay antidepressant effect is yung inhibition niya towards MAO-A nga enzyme. Okay? Kay siya man ang responsible nga ga-metabolize sa serotonin ug norepi. So kailangan yun nato ni siya i-inhibit generally ang MAO-A, producing an antidepressant activity. Okay? So straightforward lang basim ingon tag MAO-Is drugs na ha, monoamine oxidase inhibitors in general, they inhibit the enzyme MAO. Okay? Preventing therefore metabolism of monoamine. So in general, kung makadungog kag MAO-Is, straightforward naman ang iyang meaning, di ba? Or iyang action based sa term MAO inhibitor. So ga-inhibit siya sa MAO. Kung ma-inhibit ang MAO, prevented ang metabolism ng mga monoamine, okay, nga neurotransmitters. Okay? Now, we have two general MAO inhibitors. Okay, natay duha ka general classes of MAO inhibitors. We have the non-selective, then the other one is selective, nga MAO-Is. Okay? Now, when we say non-selective, di siya gapamili. Hindi siya maarte, hindi siya namimili. Okay? Biskan kinsa iyahang i-block. Kaya niya i-block si MAO-A, kaya niya i-block si MAO-B. Okay? So examples of this are phenelzine, isocarboxazid, tranylcypromine. Question, non-selective MAO-Is, pwede ba sila as antidepressants? Yes or no? Non-selective MAO-Is, pwede ba sila? Okay? As antidepressants. Yes, very good. Okay? Because non-selective na gyapon sila ability to inhibit MAO-A. Okay? Thus, they possess antidepressant activity. Okay, taani ang non-selective MAO-Is. Next, kung may tag-selective MAO-Is, okay? Selective siya, maarte, tamili. Okay? Pili lang ang iyahang inhibit. So we have what we call selective MAO-A inhibitor. So as the term suggests, iyaharang gina-inhibit ang enzyme nga subtype A, MAO-A. Balik ta diri para asa di ang MAO-A. Siya ang ga-degrade sa serotonin ug norepinephrine. Siya ang ga-degrade sa norepi ug serotonin. Therefore, kung ato siyang i-inhibit, what will happen to the level of serotonin and norepinephrine? It will enhance, no, the level of norepi, serotonin. Kag inhibit man niya ang enzyme nga responsible to degrade norepi and serotonin. So a good example of this drug is moclobemide. Okay? Moclobemide. It has nothing to do with dopamine. Okay? Wala siya action towards enhancing dopamine level. Iyaharang gina-enhance this one. And other related nga mga monoamine, okay, nga gina-inhibit ni MAO-A. Whereas selegiline, it selectively inhibits subtype B, okay, nga enzyme, MAO-B enzyme. Okay? Therefore, among the list of MAO-Is, okay, MAO-Is, among the list, selegiline is not recommended for depression. Okay, based sa iyahang action, ang iyaharang gina-inhibit, MAO-B. Balik ta kay MAO-B. Kani ang gina-inhibit, MAO-B. Para asa ang MAO-B? Siya ang ga-degrade sa dopamine. Therefore, kung i-inhibit nato si MAO-B, ang mahitabo, enhance ang dopamine only. Padayon ang degradation ng norepi, serotonin. Kaya wala man siya action towards MAO-A. Available gyapon ng MAO-A. Ang iyaharang gina-inhibit is MAO-B. Very selective siya kay. Therefore, this is not recommended for depression. Okay? Now, if this drug is not for depression, then based on its action, okay, nga gapa-enhance siya sa dopamine level sa brain, selegiline is then very effective agent for the reduction ng symptoms of Parkinson's disease. Okay, symptoms of Parkinson's, okay, disorder or disease. I have mentioned Parkinson's last meeting. Ano yung underlying problem sa Parkinson's? Mababa yung dopamine level. That is why ang selegiline very good siya to reduce the symptoms like tremors, okay, spasms, rigidity, okay, during Parkinson's disease, kay pinapataas niya yung dopamine levels. Okay? So again, selegiline, not for depression, but it may be useful for Parkinson's patient. Okay? Now, based on practice, okay, practice karon sa psychiatric nga case management sa patients, ang mga MAO inhibitors, non-selective, MAO-A inhibitors, they are usually the last choice of antidepressants. Dili gid sila ang una ginahatag. First line again is SSRI. Second line, SNRI. Siya ang last choice. Kana lang yung dili gid ga-respond ang pasyente ato nga mga dapat ihatag nga mga drug of choice for depression. Okay, kung di na gid responsive ang pasyente, last choice na gid ni ang MAO-Is. The main reason nga nung siya gid ang last choice, dili gid siya ang piliun bitaw, in the middle, last gid siya. Okay? Kasi, take note, MAO-Is, they show higher incidence of drug-to-drug interaction, and especially drug-to-food interaction. Okay? Let's say, for instance, earlier, I have mentioned, di ba nga, ang MAO, ang monoamine oxidase nga enzyme, they are distributed in the bodily tissues. Diba, anak ko? Pwede siya sa brain, na ay MAO enzyme sa stomach, na ay MAO enzyme sa liver. Okay? So, yung MAO enzymes found in the stomach, okay, for instance, sa stomach ha nga MAO enzyme. So, siya tig-degrade, no? Kato nga MAO enzyme sa stomach, very important to siya in breaking down monoamines ingested from food. Example, tyramine. Tyramine, it is a monoamine based on its structure. It is a monoamine based on its structure, tyramine. Asa man ni siya ga-contain? Example sa cheese. Cheese, cheddars, pineapple juice, etc. They are rich in tyramine. Okay? And MAO enzymes, take note ha, MAO enzymes, they are responsible to degrade the tyramine. Okay? Kailangan na i-breakdown ang tyramine para ma-excrete sa body, di ba? So again, ang MAO enzyme, it breaks down tyramine. Now, talking about tyramine, okay, once dili ni siya ma-accumulate di ay. Once ma-accumulate ni siya sa body, okay, this could be a source of tyrosine na amino acid. Tyrosine. Okay, so na-mention ako si tyrosine ganina ba? Isa siya ka-precursor ng isang monoamine neurotransmitter. So na mo yung somehow idea. Si tyramine, once ma-accumulate sa body, dili siya ma-broken down. This could be a source of tyrosine. Okay? Now, ang problema karon kung ang patient is taking MAO-Is. Okay? MAO-Is in general. Okay, mga drugs nga ga-inhibit sa MAO. So sa stomach, ang MAO sa stomach, okay, magpabilin, 'di ba? Okay? Magpabilin ang MAO inhibit Dili siya magpabilin, ma-inhibit, okay? Gina-inhibit man niya ang monoamine oxidase, inhibited ang action ng MAO. Dili niya walay mag-degrade sa tyramine. Walay mag-degrade sa tyramine. Okay? Now, what will happen to tyramine? It will cause build-up of tyramine. It will be uptaken into the synaptic nerve terminals. And it will act as a source of tyrosine. Para asa di si tyrosine? Balik ta dire. Asa dito si tyrosine? Para siya precursor for synthesis later on ng norepinephrine. Magsugod gid kay tyrosine. Okay? So with large amounts of tyrosine, okay, paspas ang synthesis ng norepi. So butang tataas, as if, taas na, norepi. Take note, what is the general action ng MAO-Is? May it be mo inhibit og MAO-A or MAO-B. In general, unsay ang MAO-Is? Di ba? They inhibit MAO, okay? That is supposedly must degrade serotonin and norepi. So kung inhibited yung MAO, increase, enhance, continuous ang level ng serotonin and norepi. So butang nato diri. So with MAO-Is, atong i-pair up. Taas pod ang norepi, for instance. Diba? Tama? With MAO-I, taas ang level ng norepi. With MAO-I, dili ma-inhibit. Okay? Ang MAO sa stomach, nga dapat mo degrade kay tyramine. So accumulated, mo build up ang tyramine. Tyrosine will be used as a source of synthesis ng norepinephrine. So as observed, na ay double effect nga mahitabo. Diba? Double effect ni siya. Drug to food interaction. Okay? Now, what will happen kung may norepi? Asa man ipadulong ang norepi? Diri naman na sila langoy-langoy sa systemic circulation. Diba? Mo attach, mo bind, man yun na sila sa receptor. Asa ni sila padulong? Alpha 1, beta 1. Huna-huna, unsay mahitabo kung excess norepi, norepinephrine, mo bind, okay? Na ay upregulation sa receptors alpha 1, beta 1. There would be hypertensive crisis, okay? This will result, therefore, okay, to hypertensive crisis. Hypertensive crisis. So in relation, wrong spelling. In relation na siya sa excessive norepinephrine nga accumulation. With this drug to food interaction, so delikado siya, no? Ang MAO-Is, that's why last choice gud siya, last choice to be given as antidepressant. Ang worst pag yun, hypertensive crisis to pwede cerebral stroke, no? Norepinephrine cerebral stroke ang patient. So, delikado siya. That is why ang pasyente, if ever gyud wala na gyud choice, unresponsive gyud ang patient sa mga other nga mga antidepressant, walay choice, gitagaan siya og MAO inhibitors. MAO inhibitors due to lack of options, wala na gyud lain. MAO ay ra gyud ang atong mahatag ani nga patient. Unsa ang atong buhaton? Ihatag. Pero naay proper counseling dapat. Unsay ingnon sa pasyente? Ma'am, sir, please avoid tyramine rich nga mga food. So hatagan nimo siya list, bawal ka ani, bawal ka mukaon ani ana. Okay? So that's the way para at least, 'di ba, mahatagan natog proper intervention pa rin ang pasyente. Okay, despite the lack of options, unresponsiveness niya sa other nga mga first line, second line antihypertensives. Proper counseling lang dayon. Okay? So delikado siya. Okay? Sige. Done. No, overall done with typical antidepressants. So kung inyo siyang i-scan, later on pag take down ninyo pagsulat ninyo sa inyong notes, ninyo i-scan ang 1 to 4. Okay? 1 to 4, diri na lang. Kani sila, ma-realize ninyo nga, typical antidepressants yun sila. Kay ang ilag yung action, kay ga-focus ra gyud sa norepinephrine, okay, and serotonin, okay. Ila ra yung gipa-enhance ang serotonin, norepinephrine level. Wala na sila other nga miscellaneous activity towards antidepressant activity. Okay? So finally, dito sa number 5. Number 5, atypical antidepressants. Okay? Atypical antidepressants, okay, as mentioned earlier, ingon ko, atypical ganing antidepressant, they exhibit action at several different sites. So aside from focusing on the reuptake process, on MAO inhibition, nasa like other nga sites of action. For example, okay, diretso na ta sa example ng mga atypical antidepressant, bupropion. Okay? Mechanism of action niya, it equally inhibits, again equally, butang na to, equally inhibits reuptake of norepi and dopamine. Okay? So meaning, ano siya, norepinephrine, dopamine, reuptake inhibitor siya. Okay? Sulat na ako ha, norepinephrine equals dopamine, then reuptake inhibitor. Okay? Basta gani reuptake ang iyahang gina-target, reuptake process, katong transporter, iyang igon. Kaya di ba, for it to be reuptaken sa pre-synapse, kailangan og transporter. Kailangan na siya sakyan, okay? Para mahatod siya pabalik sa iyang destination. So kato yang i-target ang transporter. Kaya ang reuptake, it is a process. Kaya asa man nimo pangitaon ang word nga process ra na siya. Okay? Now, based on its MOA, kani nga agent is contraindicated therefore sa patient with psychosis. Ngano man? Inhibition of reuptake ng dopamine. Okay? Gi-inhibit ang reuptake ng dopamine, so available siya sa cleft. Enhance ang dopamine level. Bawal siya sa mga patients with psychosis, especially schizophrenia. Diba? Contraindicate siya sa patient with schizophrenia. Kasi, diba, schizophrenia, more on katuyang positive symptoms, it is because of the hyperactivity of dopamine sa mesolimbic system. Now, bupropion, aside sa iyang antidepressant activity, it may also be used for smoking cessation. It is because yung drug mismo, na siya ability to reduce nicotine cravings. Okay? Especially, kanang during withdrawal symptoms ng person, kanang iyang abrupt i-withdraw ang smoking niya nga practice, na sila ma-feel nga mga withdrawal symptoms. Okay? Mag-crave na noon na sila more on nicotine, mangita na noon na sila kung abrupt. Once mag-decide ka nga mag-stop na gyud, okay, sa smoking, hinay-hinay, gradual. Okay? Dili pwede abrupt. Kay delikado na siya, na ay withdrawal symptoms nga ma-feel. Mas musamot na noon ka og crave for nicotine. Okay? So, bupropion, it may be used for smoking cessation. Another drug is mirtazapine. Mirtazapine, it inhibits presynaptic alpha-2 receptors. Okay? Somehow na mo yung idea no sa presynaptic alpha-2 receptor. Balik taning process. Okay? Sabi doon, giyang gina-inhibit ang alpha-2. Ahal makita ang alpha-2 receptor. Alpha-2 receptor sa presynapse. Alpha-2, alpha-2. Para asang alpha-2? Once ma-activate siya, di ba, autoregulation, meaning, pag activated ang alpha-2, autoregulation, pigil ang further release ng neurotransmitter. May it be serotonin, may it be norepinephrine. Okay? Therefore, kung atong i-inhibit, okay, i-inhibit nato ang alpha-2, presynaptic alpha-2 receptor, opposite, walay autoregulation, continuous ang release ng norepi, continuous ang release ng serotonin. Okay, so pwede siya as antidepressant, mirtazapine. So that's one of its activity, inhibiting presynaptic alpha-2 receptor. Another, naapod siya activity towards blocking serotonin receptor in the postsynapse. Okay? This is not the same mechanism ha, kung moingon tag reuptake ng serotonin. Okay? Kaya ang yamang igon ana is ang transporter. Kung moingon kag it blocks the serotonin receptor katong nasa postsynapse nga mga receptor. Kung asa mo bind ang serotonin, mo to yang gina-inhibit, gina-block. Okay? Another thing, napod siya ability to block histamine receptors. So that's mirtazapine. Okay? So, all in all, with this action, 'di ba, enhance ang norepi, enhance ang serotonin, okay? Thus, pwede siya for kani sa presynaptic alpha-2, pwede siya for antidepressant. Okay? Now, aside from its blocking activity sa presynaptic receptor, sa postsynaptic serotonin receptor, it can be recorded, it has recorded nga naa siya'y histamine receptor blockade activity also. Mo ni ang reason nga nung ang adverse effect common sa mirtazapine is sedation. Okay? Mirtazapine, ang pinakareklamo gyud sa pasyente kung hatagan siya, ani nga drug is kanang dali ra kay siya katulgon bitaw. Okay? That is because of its activity towards blocking histamine receptor. Okay, last na lang. Trazodone and nefazodone. Trazodone, nefazodone, yung MOA naman nila is towards blocking, okay, reuptake of serotonin. So, iyahang gina-target ang SERT, ang transporter. Another thing, na siya ability to block, okay, serotonin 2A receptor. Okay? It blocks serotonin 2A receptor. In addition pag yun, na po siya ability to block H1 receptor. Okay? Now, I want you to be familiarized with the adverse effect, no, ng both. Okay, both drugs. Okay, the same with mirtazapine. They also manifests highly sedating effects. Okay, highly sedating kaayo ni sila nga mga agent. So atong i-relate, based lang gihapon na siya yung ability to block H1 receptor. Okay? Nefazodone, withdrawn na ni siya sa market. Okay? It has been withdrawn sa market due to its hepatotoxic. Okay? Hepatotoxic nga adverse effect. Okay? Nefazodone. Okay? So, I think we are done. Supposedly, mag-discuss pa ko for bipolar katong mood stabilizer, but we have no time. So, ako na lang gihapon siyang i-add here or maghatag lang kog link. Kuha na lang siya mga 3 minutes siguro. Inyo lang siyang i-access ang video for you to understand the mechanism of action ng mga mood stabilizer towards managing bipolar disorders. Okay.